Hi friends, welcome to the next part of Dysmenorrhea Part-2. So revising what we learn in dysmenorrhea. One is our important ovarian dysmenorrhea case, how it approached and how did we come to know. Then the anat physio part, patho part of any subject, which we always have the template and how we go about, and basic investigations and classification of dysmenorrhea, primary and secondary, and few investigations is something which we taught. So now coming to the workup of primary dysmenorrhea. Why do you think I laughed? Because this is something which everyone knows. I mean, there is no need to take up a separate class for it, but for sake of completion, I am doing it. See, if a very classical patient, you will never, I mean, there's nothing to, remember or do something. An adolescent girl, I mean, 13 to 14-year age, usually they have, see, HPO axis is not at all matured. I mean, might not be matured in this case. So what happens is they will have pain. Go with a general template: history, examination, investigation, treatment. Correct, no? This is how we go for any patient. So you will ask for history. When do you get the pain? So usually in primary dysmenorrhea, no, when do you think the pain starts? It's something when the onset or just before the menses start. Okay, so onset of the menses is when your pain starts. So that is classically like of primary dysmenorrhea. But in case of secondary dysmenorrhea, you might have 7 to 10 days between the onset of menstruation, or if it's systemic cause, then you might have throughout. Okay, so based on that only you can come whether it's primary or secondary. The demographic details, the age will always lead to some conclusion for your cases, right? So that is something which is very important. Then what do you think? Examination as such, you can just go with your general physical examination, no positive findings, but per abdomen you can do, you might find tenderness, okay, in few cases. That's it. Investigations, again, in primary dysmenorrhea, please, there is nothing to do. Evaluate, I mean, in the primary healthcare approach, you just see, give some medication first. I will talk about the medication first. You need to give some advice, man. I know in this age, no, they don't need advice. I mean, they don't pay attention to advice, but it's your duty to give them advice, right? So just give advice. What you give, assurance and education that this is common, this might happen. After 2-3 years you will have a normal life. Then advise her to go for aerobic exercise and diet which has low fat and other rich vitamins, and if required, keep herself active or something like that, or busy in her own work. That should work. Advice. If it is again disturbing in the day-to-day life activities though, then obviously you can start her on NSAIDs. Okay, so see, when it comes to primary dysmenorrhea, there is something called as non-pharmacological approach. That is the advice which I taught. Then there's something non-hormonal approach. What is non-hormonal here? NSAIDs only. You can start her on mefenamic acid. Okay. Then again, what is that? I told everywhere it comes. Yeah, hormonal. What? OCPs you can give. Okay. That will try to increase the progesterone level so that it maintains the thing. Then again, I have to say this, but I don't know how far they do it. But there are some surgeries where see, the problem is in a nerve, right? So you can either go with uterine nerve ablation. Okay, I don't know whether these things are done, but for completion's sake I'm saying, then you can remove the neural part from sacrum. That is, I'm sorry, yeah, that is pre-sacral neurectomy. Then if required, you can go for dilatation of cervix. Before all these things, no, a diagnostic laparoscopy is something which has to be done so that you will rule out any other pathology if it is present in the abdomen. Got it? So this is the approach for your primary dysmenorrhea. Then is the workup. Okay, So I think, see, again, one more thing which I need to highlight now. If she's a case of if she's a reproductive age group and if she needs contraception, directly you can start her on OCP. That is one thing which I need to say. So I have told you. So that is one more thing. Now other cases, no. I think last time we discussed ovarian dysmenorrhea. I think we discussed classical case. Should not forget that. Then there's something called as ovulatory pain. At the time of ovulation, she will have pain. Okay. Again, nothing to say. Expectant management. If severe, NSIs. That's it. Okay. There's nothing to teach here. Okay. I mean, if you know, you have seen, you know. Ashte. Then there's something called as premenstrual syndrome. What does it mean? Before the menses, you will have pain. That is premenstrual syndrome. So implies what? They will have pain in second half of cycle. Correct? No. Why do you think? Hormones, man. If you know the menstrual cycle, you know well. So in the second part, no, there is again imbalance between estrogen and progesterone. So again, I told, no, in anat. Yeah, you remember? Neuroendocrine. So imbalance between serotonin and other GABA or something. Okay, endocrine related to hormones, some hormonal imbalance. So that can cause premenstrual syndrome. So what do you think is treatment? Direct progesterone. See, again, advice. Sorry, expected management. Then if you want, you can start her on progesterone. That is OCPs. Never done, but yes, this is what you should know. Okay. This is one case. Then other case also, there's something called as PMSD. So what is PMSD? Same as premenstrual syndrome disease, premenstrual syndrome. See here, all these things, no, there's something called as psychology. That is what very important. You need to counsel them very, very properly. Otherwise, I think it comes under the classification of DSM-5. I mean, states some disease. Okay, I'm not sure. So this is again something to do with psychiatry. I'm not touching upon. So again, if there is a case of dysmenorrhea under secondary causes, secondary pathological cause, you can have anything related to pelvis. Okay, or adenomyosis, CA cervix, which we'll discuss in subsequent classes, because this is not an approach this is something as a different approach. No, this is just for expectant management. You can just give them NSIs. So briefly we'll discuss somewhere in other videos. So this is not that required. So what happens is, see, there's something called as pelvic congestion syndrome. So what happens? This is sacrum, no, pelvis, no. Here you will have all your ligaments, muscles, veins and stuff. So at the end, what? If you harm nerve, it will give pain. So excessive congestion, no, here in vessels or in any ligaments, if it presses on nerve, it leads to pain. Okay, that is something which you know. That is the etiology. That is pelvic congestion syndrome. Okay, usually seen in premenstrual syndrome itself. So I think that should be enough for you, for your workup of primary dysmenorrhea and things which you should know in the part. So, and also something which I forgot is cryptomenorrhea. Okay. What do you think will happen in cryptomenorrhea? What is the pathology? Yeah. This is what is crypto and what is menorrhea. Say etymological meaning is something which you should know. So I think this I will take up in the third video, and I will summarize all the diseases which you should know in in dysmenorrhea, so that you will have a better hold on the subject. So what is the pharmacological aspect of it? NSAIDs. I mean, first is advice, NSAIDs not working. Then you can start around progesterone if it's something to do with hormone. Then if it's something related to psychiatry, SSRI, SNRI, because hormonal imbalance, right? So that we'll discuss in the last video of dysmenorrhea, where we touch upon all diseases as such. But speaking as such, for the exam point of view, this is not that important except cryptomenorrhea, I guess. But for your practice, this is something which you should know. Okay, I think by that, I think this should be enough. Okay, I'll see you in your next video. Take care. Bye bye.